Hello, today we are going to start a very important topic, that is polymerase chain reaction. Under this topic we will see the definition, principle, different steps and types of PCR along with its application in pathology and hematology, and the advantages and limitations of this procedure along with some important exam points. So let's get started with the topic. What is PCR? PCR is defined as an in vitro molecular technique that amplifies a specific sequence of DNA exponentially through repeated enzymatic cycles using a thermostable DNA polymerase enzyme. In a nutshell, the PCR is a molecular photocopier for DNA. So what are the steps? There are three main steps, that is denaturation, annealing and extension. Before that, I want to show you the steps of PCR. So this is our DNA sample. In step 1 there is denaturation, which happens at 95 degrees centigrade. Under this step, the DNA is broken into two separate strands. This is the first strand and this is the second strand. After that, in step 2, the process of annealing happens at 55 degrees centigrade. Under this step, there are two primers which attach with the DNA strands. This is the forward primer and this is the reverse primer. These primers anneal between each DNA strands, and these are the nucleotides. These primers form another strand of DNA with the help of these nucleotides. In the next step, extension happens and a new DNA strand forms with the help of the nucleotides or the DNTPs. And likewise, two new DNA strands have been formed. That is, this is first double-stranded DNA and this is the second double-stranded DNA. So from in our sample, from one double-stranded DNA, two double-stranded DNAs have been formed, and like in the likewise manner, the cycles are repeated maybe 20 to 40 times. So the number of DNA strands is 2 to the power n. N is the number of cycle. So the denaturation happens at 94 to 95 degrees centigrade. And in this step, DNA double helix unwinds and hydrogen bonds between the two strands of DNA breaks. Annealing happens between 50 to 65 degrees centigrade and primers bind to the target DNA sequence. In extension, which happens at 72 degrees centigrade, the Taq polymerase or the DNA polymerase enzyme synthesizes new DNA. And total 25 to 40 cycles of PCR happens, and this makes millions of DNA copies exponential. That is, the exponential amplification of DNA happens. So what are the requirements for PCR? PCR requires a sample. It may be a blood or a tissue or a swab sample. It is the source of the target DNA sequence to be amplified. And we also need two primers. The primers are the short single-stranded oligonucleotides, which are around 18 to 25 base pair long. These are forward and the reverse primers which flank the target. And the Taq polymerase or the DNA polymerase enzyme, which is thermostable enzyme from Thermus aquaticus. It is active at 72 degrees centigrade and withstands a denaturation cycles. DNTPs, that is deoxyribonucleoside triphosphates, that is DATP, deoxyadenosine triphosphate, DCTP, deoxycytidine triphosphate, DGTP, that is deoxyguanosine triphosphate, and DTTP, that is deoxythymidine triphosphates. These are the building blocks for new DNA strands. We also need buffer and magnesium ion. This maintains optimal pH, and magnesium ion is a cofactor for Taq polymerase enzyme. Their concentration affects the specificity of the process. We also need thermal cycler, that is, it is a programmable machine that rapidly shifts temperature between the denaturation, annealing and extension steps. So this is all the gist what we have studied earlier, and this is the denaturation process, annealing process and extension process. The denaturation process results in two single stranded templates, and in annealing process the forward primer attaches to the sense strand and reverse primer attaches to the anti-sense strand. In extension, the synthesis occurs in the 5' to 3' direction, and in this process new complementary DNA strand is formed. Now what are the types of PCR? There are multiple types of PCR. One is the conventional PCR, which is used for detection of the DNA, and the real-time PCR, that is also called the quantitative PCR, which is used to quantify the amount of DNA or RNA present in the sample. In this PCR, we need fluorescent dyes, that is cyber green or Taqman probes. It is a real-time quantification method which helps in detection of the viral load also. Now the nested PCR, this process is highly sensitive and specific type of PCR. In this PCR, 2 rounds of PCR happen simultaneously and it reduces the false positive results. This is the reverse transcriptase PCR. Reverse transcriptase PCR, which is used for the detection of the RNA viruses and gene expressions. In this process, the RNA is first converted into complementary DNA using reverse transcriptase enzyme, and then the PCR amplification is done on the complementary DNA. Next is multiplex PCR. Multiple DNA sequence is targeted simultaneously under this process. Multiple primer sets in one direction and used in respiratory pathogen panels detection. Next is the digital PCR, also called as droplet PCR. In this PCR, absolute quantification of the target sequence is done, and it also doesn't need a standard curve like that of the conventional PCR. Under this process, the target sequence is partitioned or divided into thousands of droplets, and then PCR happens on each of the droplets and then counted as positive or negative as the fluorescence is present or not. This will give the positive or negative result, and then all of the positive and negative results are assessed statistically to determine the quantity of the target DNA. Now the applications of PCR in pathology. In hematopathology, PCR is useful in detection of BCR-ABL1 fusion in CML, PML-RARA fusion in APML, acute pro-myelocytic leukemia, IGH-TCR gene rearrangement for clonality assessment, whether it is B cell or T cell, for detection of minimal residual disease monitoring, and in FLT3, NPM1 mutation in AML. In oncopathology, it is helpful in detection of EGFR mutation in lung adenocarcinoma, KRAS, NRAS and BRAF mutation in colorectal and melanoma, HER2/neu amplification in breast cancer, BRCA1 and 2 germline mutations, microsatellite instability testing also. For the diagnosis of infectious diseases, PCR is also very important. It helps in the detection of Mycobacterium tuberculosis, and the Gene Expert and CBNAT processes are based on the principle of PCR. For detection of viral load in case of HIV, mainly by RT-PCR, because we know HIV virus is a RNA virus. Hence, first RNA is converted into DNA and then PCR is done on the DNA. Hence, it is a reverse transcriptase PCR. For the detection and quantification of HBV and HCV virus, and also in detection of the HSV, herpes simplex virus, cytomegalovirus and Epstein-Barr virus in immunocompromised patients. It is also helpful in HPV genotyping of high risk type of HPV, that is type 16 and 18. It is also helpful in COVID-19 diagnosis. For COVID, RT-PCR is the gold standard procedure. It detects SARS-CoV-2 RNA, mainly the N4 nucleocapsid, E envelope gene and ORF1ab gene. The nasopharyngeal and the oropharyngeal swab samples are needed for PCR. The sensitivity is 95% and specificity for detection of COVID is 99% by PCR. The CT value or the cycle threshold value reflects the viral load. Now the advantages and limitations of PCR. We know that it is a very sensitive and highly specific process. It is a sensitive process because it can detect even a single copy of target. That is, the femtogram level of DNA can also be detected by this process. And it is specific because the primer design ensures target specific amplification. Only that target of the sequence will be targeted that we want to amplify. So it is a very specific process. Next is the rapid turnaround time. It gives results within hours. It is faster than the culture methods. The small sample is needed, even it works on the degraded DNA samples. Like if FFPE tissue is present or a dried blood spot is present. It is a very versatile process and which can be done on DNA or RNA, and it has different variants that are available like quantitative, multiplex or digital. It can also detect non-viable organisms, because in culture only viable organisms can be detected, but in PCR non-viable organisms can also be detected. Now the limitations. The main limitation of this process is the contamination, because it gives the false positive results. The contamination happens due to the carryover of amplicons, so it needs strict lab precautions, and a pre and post PCR zones are needed. This process cannot assess the tissue architecture or the morphology. For that, we have to always correlate it with histology. The primer designing is critical, because if in primer designing error happens, then amplification will not happen and it will not give specific bands. If inhibitors in the samples are present, then it can inhibit Taq polymerase enzyme. The inhibitors can be the blood FFPE fixative or the heparin. This process needs an expensive setup, which requires thermal cycler, reagents, BSL2 facility, so are not universally available. By this process, some novel mutations or the unknown variants can be missed if probe or primer doesn't match each other. Now the controls in PCR. There are different types of controls that can be used for PCR. Out of that, positive control, negative control, internal control and extraction controls are important. The positive control is a known positive sample which is run alongside the test, and it contains the same sequence of DNA that we want to amplify in our sample. This ensures that the reagent and techniques are working fine. Negative control, that is no template control. It is not containing any DNA present. In spite of DNA, the water is present. So ideally there should be no amplification or band formation. But if there is contamination, then it will show band. In internal control, some genes, that is housekeeping or the endogenous genes, are co-amplified along with our target sequence of DNA. This confirms DNA quality and absence of inhibitors. Extraction control, this monitors DNA and or RNA extraction efficiency and ensures that the sample processing step is adequate. So, PCR in hematopathology and the key markers. The molecular markers that are targeted in PCR is which gives clue about the disease. So, in case of CML, we target BCR ABL1 fusion gene. This is translocation T922 or the Philadelphia chromosome, and it helps in diagnosis and tyrosine kinase inhibitor treatment response and also minimal residual disease monitoring. In case of acute promyelocytic leukemia, the PML RARA fusion is detected by PCR, and this correlates with the translocation T1517, and it helps in the diagnosis and ATRA response and monitoring. In case of AML, different fusion genes can be detected like FLT3 ITD fusion, FLT3 NPM1 fusion and FLT3 SEPA fusion. This helps in risk stratification and monitoring targeted therapy. In case of ALL, BCR ABL1 one fusion is detected, but the weight of the fusion gene is different from the BCR ABL1 fusion of CML. It is 190 kilodalton in ALL and it is 210 kilodalton in CML. So it helps in high risk in diagnosis of high risk ALL and MRD monitoring. It also helps in CLL or NHL, non-Hodgkin's lymphoma, by detecting IGH gene rearrangement because it helps in the assessment of clonality of B cell. In T cell lymphoma, TCR gene arrangement is detected and it gives clue about the clonality, that is T cell clonality. In certain lymphomas, mainly in follicular lymphoma diagnosis, we detect BCL2 IGH fusion, and we know that it is translocation T1418. Likewise, in case of mantle cell lymphoma, I am writing here, mantle cell lymphoma, we get cyclin D1 IGH fusion by PCR, and in case of anaplastic large cell lymphoma, we can get NPM1 ALK fusion. Now the PCR in infectious diseases and COVID-19. In infectious diseases diagnosis, we know that GeneXpert and CVNAT is based on the principle of PCR, and it helps in detection of Microbacterium tuberculosis, and rifampicin resistance can also be detected, and it gives result in just in 2 hours. For HIV, the viral load can be detected and it helps in treatment monitoring. For HBV/HCV, viral load, genotyping and treatment response is assessed. In case of HPV, high risk genotype 16-18 can be detected, and CIN grading can also be done. For herpes virus, the PCR is done on CSF sample in case of encephalitis patient, or if the patient is immunocompromised, then on blood it is done. In case of COVID-19, it is a gold standard procedure. The samples needed are the nasopharyngeal or the oropharyngeal swabs, and in severe cases, bronchoalveolar lavage sample can also be used. The targeted genes are the nucleocapsid gene, envelope gene, and the ORF1 AB gene. The CT value or the cycle threshold value should, if it is less than 25, then it indicates high viral load, and if it is more than 35, then it indicates low viral load or the borderline. Sensitivity of this process is around 95% if nasopharyngeal swab is used, and 70 to 80% if throat swab is used. Specificity is around 99%, and the false positive results are very rare. Now some high yield Viva points. What is the role of magnesium ion in PCR? It acts as cofactor for Taq polymerase enzyme. It affects the specificity and yield of the process. And the optimal value that magnesium should be present is 1.5 to 2.5 millimole. Why is Taq polymerase preferred? Because it is a thermostable enzyme which we get from Thermus aquaticus bacteria, and it survives 95 degrees centigrade of denaturation, and it lacks 3', 5' proofreading. What is the most common PCR error? It is the contamination, and it gives false positive results, which can be prevented by separate pre and post PCR zones and using negative controls. Is RT-PCR and real-time PCR same? No, the RT-PCR is the reverse transcriptase PCR, in which we are converting RNA to DNA, and then the PCR is happening on the DNA, on the complementary DNA. But in real-time PCR, it is a quantitative process. In this process, we are quantifying the amount of DNA that is present in our sample in real time, and it is using it is a fluorescence based method, the real-time PCR. What does CT value indicate? The CT value indicates the cycle threshold, that it is inversely proportional to the initial template or the initial amount of the DNA present in our sample. Lower cycle threshold means higher viral load. PCR versus culture for TB. We know that the GeneXpert is based on PCR, and it gives faster result within 2 hours, and also detects the viable and non-viable organisms both, and also detects the rifampicin resistance. But the culture gives result in around 6 weeks time, and it gives only the viable organism diagnosis only. What is MRD and how is PCR used? MRD is minimal residual disease, and it is detected by PCR. That is, MRD is one tumor cell, one neoplastic cell, or one leukemic cell per 10 to the power 4 normal cell is the MRD. PCR detects MRD and BCR, ABL or IGH rearrangement post-treatment and guides the therapy decision. So summary and the key take-home messages are: the PCR amplifies DNA exponentially via 3 steps, that is denaturation, annealing and extension. Taq polymerase from Thermus aquaticus is a thermostable enzyme. It requires magnesium ion as a cofactor, and around 25 to 40 cycles yield millions of copies of DNA. RT-PCR converts RNA to complementary DNA used for RNA viruses like HIV, HCV, COVID-19, and it is different from the real-time PCR or the quantitative PCR. Gold standard for COVID-19 is RT-PCR. CT value is inversely proportional to the viral load. Less than 25 indicates high viral load. The key hematopathology uses are BCR ABL1 in CML and ALL, PML RARA fusion in APML, and IGH TCR clonality assessment and MRD monitoring. The major limitation is contamination, which gives rise to false positive results. So we should always include negative control and positive control. Thank you.